Now to our program today. Labor Day was one of the deadlines for release of President Clinton's health care reform plan, but the date has been pushed back again to later this month. We're still on schedule with our health care speaker, however, and he'll explain to us the forces at work that are already reforming health care, as well as what the President and Congress may do. There's no better speaker on the transformation of the healthcare industry than someone who's making it happen. Jeff Goldsmith has always been on the leading edge of healthcare, whether at an academic medical center like University of Chicago, consulting with international biotechnology companies, or serving as a health policy advisor to other governments. Jeff is an original thinker and an astute observer of healthcare, which is why he was attracted to the program committee as a speaker on this topic. We also take pride that this author and lecturer and Ph.D. from the University of Chicago is a native Oregonian. For little personal tidbits, a graduate of Lake Oswego High School, class of 1966, and Reed College. Jeff is susceptible to invitations to speak in Portland. The club hosted him in 1985, and the reception he received then suggests that the next hour will be very interesting indeed. Jeff Goldsmith.
Thank you, Mary. Good afternoon to all of you. It's really good to be here. I'm honored by your invitation to come back here. As Mary said, it wasn't a hard sell at all. I mean, it seems like several lifetimes ago that I actually lived here, but I'm still an Oregonian. It wasn't quite as fashionable to live here when I was here. But it's good to be back. I also want to thank my family for pitching in and helping fill up all these tables. I mean, you know, you really have to. You really have, you know, and you know you can count on people to bail you out of a potentially embarrassing situation. We had no idea how many people would actually come on the Friday before Labor Day, but it's really nice to be here, and I want to thank my family for helping. Well, the suspense is killing us. I mean, what exactly is President Clinton going to propose that we do to change our healthcare system? I mean, we are 4 months past his initial May 1st deadline for proposed reform, and I think, you know, 7.5 months worth of foreplay, even the hardcore health policy wonk has begun to lose focus a little bit. I had a marvelous cartoon that I was going to show you that when I use slides that showed the metaphor for healthcare reform is this ambulance going code red with all of its lights flashing and sirens blaring, but up on blocks, which kind of conveyed this flavor of all of this noise but no real movement. But the fact is that most of the substance of this proposal is already public, and that all but the all-important minutiae have leaked out. We already know the theme, health security. We know the gimmick. There's going to be a card that you're all going to get. The substantive details have also leaked. The driving wheel for the proposed reforms will be a massive expansion in the enrollment of Americans in managed care plans. We'll see anywhere from 70 to 120 million new managed care subscribers emerge from this reform. 37 million uninsured people, 32 million Medicaid recipients, and tens of millions of small business employees and individuals that can't get access to managed care right now. Now, you know, a tripling of managed care enrollment nationwide is certainly kind of a hard thing to contemplate. You couldn't triple the number of people enrolled in managed care in Portland because you have 135% of the population in the city enrolled in managed care. That's not going to work. In some places like Portland, the infrastructure is already in place to actually implement the reforms that the president will propose. In other places I visit, like Charlotte, North Carolina, or New York City, this is all going to be like a bath in the Arctic Ocean. It's going to be very difficult to create the infrastructure to absorb all of these people into managed care systems. It isn't just the problem of how to finance this without taxes that will delay phasing it in, but critical shortages of primary care physicians, the geographic maldistribution of physicians and hospitals generally, the lack of information systems, and an experience in actually changing how care is delivered. However, buried in the details of the president's proposal are some very significant and I think largely ignored changes in the status quo. The two that I'm going to talk about this afternoon is One, a virtually complete government takeover of our health insurance system, and two, a shrinking of the fee-for-service sector of our medical care payment system to probably less than 10% of total health care payment. Many people oppose the idea of managed competition, or whatever the president's going to call what he's going to propose, because they believe it will turn our healthcare system over to the health insurance industry. Those folks haven't studied the leaked documents very closely, because what the president will propose in 2 weeks amounts to a virtual federalization of our private health insurance market. Close to 80% of healthcare spending in each community will flow through a new government-chartered agency called a Health Alliance, which, while it will be local in makeup, will be controlled and essentially directed from Washington. Though the inventors of this idea, the Jackson Hole Group, who called it a HIPIC, I wonder why the president's people didn't like that term. It was too close to hiccup, you know. We have HIPICs breaking out all over the country, or I think they ended up being called, they were called something else in Florida. There are no acronyms here. Health Alliance sounds like a grand gathering together of people. The Jackson Hole Group envisioned the Health Alliance as the solution to a relatively modest problem, which is market failure of the small group and individual health insurance market, since they would have used the Health Alliance to pool the purchasing power of small employers and individuals into a very large, powerful enterprise. The Jackson Hole Group's proposal would have ended up using the health alliances to cover maybe 40% of the employed workforce. Mr. Clinton's proposal is going to encompass perhaps 90% of the employed workforce in these health alliances, along with Medicaid recipients. So this is going to be a large, powerful enterprise. And I think the reason why Clinton wanted to expand the size and scope of this enterprise was that he wanted to use it as a regulatory tool for containing health care cost. This will be done by dictating to them from Washington, from a new federal agency called, ta-dum, the National Health Board, the maximum allowable increase in the so-called benchmark premium. Are your eyes glazing over yet? This is an incredibly complicated proposal, something that I'm going to get to later. The proposal will sever the ties between the employer and health plan choice. Employers under 5,000 will no longer have any control over the health plan offerings to their employees. The employer will become a payor, a contributor of a fixed amount, 80% of the benchmark premium, which is the least expensive comprehensive health plan available in the area, to the Health Alliance. The employee will pay 20%, except where the employees' unions can get the employer to eat the employee's share. Employers will be ordered by Congress to provide their contribution, whether they do so now or not. The Health Alliance, in turn, will gather up all of this money and present a menu of choices to employees who will enroll through the alliance in the health plan of their choice using their health security card. The Health Alliance will then use its funds to pay the health plan and a premium amount subject to negotiation. The Clinton proposal would also standardize the benefits package. You saw some leaked information in the paper this morning about what that benefits package will contain, and then regulate the heck out of the insurance carriers to prevent them from exerting any influence on enrollment trends by trying to keep, unhealthy people out of their plans and those kinds of things. And I really believe, having looked at how health insurance works, that this will require literally approving their ad copy on a word-by-word basis. In exchange for all of this, the lucky health insurer will then be at risk for the cost of medical treatment for the people that choose their plan for the next year. There are a lot of conspiracy theorists afoot who believe that this plan is a vehicle for conveying control of our health insurance, of our healthcare system, over to our nation's health insurers. I see it somewhat differently. I believe that the major commercial insurance firms and Blue Cross will probably be massive net suppliers of patients and dollars to the Kaisers, Pacific Cares, and other health plans that are much more tightly organized and focused around physician groups. I believe that our managed care system will be tilting sharply away from these loosely strung networks of doctors banded together to keep managed care out of their communities, and towards very tightly managed healthcare entities that will have an advantage if they've actually been in the marketplace for a very long time. So I really see the Aetnas and Cignas and Blue Crosses getting creamed in most places because they will have a great deal of difficulty in actually containing the cost of health care. The heavy amount of regulation of the insurance industry that this proposal envisions is obviously designed to reassure the populist wing of the Democratic Party that the public interest will be protected from the clutches of what is a very unpopular institution in many places. The other issue that I mentioned, a much smaller one really than the takeover of our health insurance system, is to shrink the fee-for-service sector of healthcare payment back to maybe 10% of the total revenues in a given market. The rhetoric surrounding the President's plan will be that you will have expanded choice, and that is true because for those of you whose employers select a single health plan, you will now have a menu of health plan offerings from which to choose. You will also have less freedom, since the employer will be obligated to contribute only the amount of the least expensive plan. If your employer currently offers a more expensive plan after the phase-in period, you will be paying for the difference out of pocket. So there is going to be this paradox of more choice but perhaps less freedom. And while the fee-for-service option will be preserved and your ability to continue to choose your physician will be preserved, you will have to pay the difference between that fee-for-service plan and the benchmark plan with your own money. Now, let's talk about some of the political problems associated with getting all of this done, and I've separated them into tactical and strategic problems. The first tactical problem is that this idea is incredibly complicated. If you are confused by my brief exposition of it, I don't think it's merely a defect of my ability to communicate. I have trouble understanding how this works, and I've worked in healthcare financing for 18 years. I had an opportunity to talk to an audience of people after Alan Enthoven, who was the godfather of this idea, had spent 2 hours with them, and I gave them a little quiz. I said, and Enthoven is a person I admire, I said, you've heard 2 hours from the master about how this works. How many of you understand it well enough to be able to explain it to your mom? Okay, 3 hands in an audience of 600 people with an average IQ of 125. If you can't explain it to your mom, then how on earth is a legislator who doesn't really understand healthcare financing going to explain it to his constituency in English? If you've got to learn a private language in order to understand a policy proposal, and then you have to explain to people how it's going to benefit them, you've got a little bit of a selling problem. The other problem with a complicated idea is that it can get horribly mangled in the legislative process. I know that laws aren't made in the bright morning sunlight under the influence of a lot of coffee or whatever. They're made at 3 in the morning under the influence of a lot of coffee, when a lot of stuff that looks like, it can be negotiable is actually a vital structural member of the proposal. This proposal has been likened by its opponents to Star Wars in its complexity, and I think unfortunately that is true. A second problem is that most of the major traditional constituencies within the Democratic Party hate this idea. I put that under tactical rather than strategic. I'm not sure why. It is viewed by, well, what is it? Pete Stark said 3 or 4 months ago that this idea was sort of the equivalent of the Laffer curve as applied to healthcare economics. I mean, that's a pretty dirty thing to say to somebody after after Reagan. He also accused the healthcare task force of, quote, reinventing the marshmallow, close quotes. The guy really is amazing in his ability to find one-liners. Most Democratic people who follow the health policy issues are saying, why go through all this nonsense when you can simply abolish the health insurance industry and let the government set prices just like they do in Canada? The Democratic health policy establishment, the people in the Eastern universities and foundations that advise the president, really view this idea as an idea that was left over from the Reagan era, which it is. If Ronald Reagan had wanted to implement a health policy, it would have looked a little bit like what you're going to see in 2 weeks. To these folks, to the labor unions that have lobbied for national health insurance for 40 years, Canada is the gold standard. And the idea of not going all the way, I think that's one of the other unfortunate metaphors that gets used here, to a national health insurance system, is going to deprive the president of the left wing of his political spectrum. So he's going to get very little help from the Republicans and very little help from half his party. Does this sound like NAFTA a little bit? I mean, it isn't, because he'll have more help from the Republicans on NAFTA than he will on this. Unfortunately, for the advocates of a single-payer system, there are probably only 100 votes in the House of Representatives and at max probably 12 in the Senate to do it. And the main reason is that you'd have to raise $400 to $500 billion in new taxes annually to take out private health insurance. Now, remember how much blood got shed to raise a piddly, what was the gas tax? $6 billion a year? $8 billion, something like that. So I think you get the magnitude of the political challenge involved. The third tactical problem, what were the two? Complexity, the Democrats hate it. The third one, the basic benefits package. Did you see in the paper this morning they talked about covering pregnancy-related services? Ooh, abortion's lurking in there somewhere. They're going to have to declare themselves on whether they're going to put abortion in the basic benefits package, and a whole ugly issue that hasn't been resolved yet is going to end up getting attached to this. But then you've also got the issue, what do you do with the chiropractors? You know, what do you do with the massage therapists? What do you do with the naturopaths? What do you do with all the alternative medicine people that are very popular in our country? You exclude them from the basic benefits package, and you've consigned them to the netherworld of, you know, MasterCard and Visa receipts and personal checks and chickens. And, you know, if they're inside the benefits package, then they've got a guaranteed lifetime income. Can you know, in Utah during the bee season, you know, they have these pictures of the beekeeper, you know, covers himself with bees to show how harmless and tame they are. That's what the Ways and Means Committee people are going to look like when they're marking up the basic benefits package. Because every single lobbyist for every single conceivable health profession will be in there trying to make sure that that basic benefits package is broad enough to include their services. Strategic problems, grandiosity. The real architect of the president's proposal was not the First Lady. Those of you that have followed the First Lady realize that she's had two horrible things happen to her during I mean, she lost her dad, she lost her best friend and law partner, Vince Foster. You know, it's amazing that she's actually been able to keep going publicly given what's happened to her. The architect of this idea is a former Boston Consulting Group management consultant named Ira Magaziner. As a person that spent the last 12 years in management consulting, I believe that management consultants are dangerous, and that when they retire, they ought to be put in pens with electric fences around them to prevent them from getting to policymakers. You forget the interest group politics of this proposal for a moment, which are daunting, and just think about the sort of physiology of it. What the president is proposing to do is to create a new conduit for roughly $850 billion through a set of agencies that will be created new by the Congress. This is, if it is to happen, the most ambitious civil engineering project since the Corps of Engineers took on the Mississippi River, because the $850 billion, the 80% of healthcare spending in our country, is a Mississippi River-sized stream of income. And the goal here is not just to create a new channel for it, but to eliminate all the elevation by taking all of the risk out of the risk pools and making sure that the insurers don't cheat and all the rest of it. While the White House envisions these health alliances as a tiny agency with a few staff, I think they will eventually employ hundreds of new healthcare bureaucrats in each area as Congress heaps them with tasks ranging from protecting consumers to assuring that women get adequate access to breast cancer, all services, all laudable policy goals, but ones that are going to end up being heaped on this little agency until there's a vice president in charge of doing every one of those mandated things. And I think you'll see the Jackson Hole crowd bailing out like crazy as their relatively modest little, you know, intermediary agency ends up becoming a, you know, something that looks a little bit more like the Bonneville Power Administration. The second major strategic problem is that there's no apparent revenue source to do all of this. I mean, I'm looking for the revenues here. The budget debate cost the president the ability to solve the problem of transition by drowning the transition in new tax dollars. And therefore, you know, we're going to end up covering 37 million uninsured Americans, 27% of which don't have a job, and another 20% of which are part-time workers or dependents of part-time workers with no new taxes. Now, where's the money going to come from to do this? Well, it's probably not going to come from Medicaid or Medicare savings, because that's not going to be very popular with the elderly or with the advocates for the poor. Well, I wouldn't be surprised to see these alliances given what are in fact taxing powers. That is the ability to impose surcharges on insurance premiums that would be picked up and re-channeled to provide a pool of dollars available for people to get covered if they're not employed. See, simply ordering employers to offer health insurance coverage is not enough. As you've discovered in this state, you've got to come up with money to pay for the people who are either not connected to the labor force at all, who are minimally connected. I mean, what is the 22-year-old kid who's taking home $80 a week going to do to buy into this system? Where's the money going to come from? Well, it's going to have to come from somewhere, and it's still not clear where. I believe the third major strategic problem is the failure to reform our nation's Medicare program. Medicare is completely left out of all of this, and I believe it is the brokenest part of our existing healthcare financing system. I think it is more broken than Medicaid. If you ask the question, why are there 37 million working poor, uninsured, when the statutory authority exists for every state in the union, including this one, to provide coverage to them through a general assistance program or a medical assistance no-grant program, the answer is real simple. That the money that would have gone to cover the working poor has gone instead to cover the elderly for the portion of the services that they couldn't get from Medicare, because Medicare continues to use an obsolete acute care-based model of payment for services. 3/4 of the nation's Medicaid program goes to pay for chronic care services to our nation's elderly. So you reform the healthcare system and leave Medicare alone. Doesn't make a lot of sense to me, but it's certain from an interest group standpoint, if you don't want the AARP burning down your house, if you want to sort of leave them alone, or you want to give them more benefits, then you basically don't tamper with the existing structure. You go and tell people in the East, hey, wait a minute, 63% of the elderly in my hometown of Portland, Oregon are enrolled in managed care plans, and a lot of them seem to actually like it, and many of them actually get more benefits than they do from the traditional Medicare program without additional cost to them, because the services are rearranged and organized better. They just look at you like you'd landed from Mars. I mean, they need to come out here and see how it works. The failure to reform Medicare was, I think, a fairly major missed opportunity. And then finally, and I think the most significant strategic problem of all, what does the typical currently insured American middle-class voter get out of all of this turmoil? The answer is not bloody much. You're going to get portability of benefits. You're no longer going to have job lock. That's the big one. That is, you will be able to continue your insurance coverage from job to job to job. If you lose your job and you want to go get another one, if you become unemployed, or you change jobs, or you get sick and then change jobs, we're not going to have any more of this dropping off into limbo. And I'm not going to minimize that. That is a very big deal. But you're also probably going to end up paying more out of pocket to continue seeing the physicians you're seeing, unless, as most of the people in Portland are, you're already enrolled in a managed care plan that you like. There's going to be tremendous dislocation and uncertainty created by a lot of this. Some of it perhaps politically motivated, the doctor saying, oh, I don't like this, or the hospital saying, I don't like it. There's going to be a lot of that. But I think there's also going to be a lot of genuine concern about, am I going to be able to continue getting my needs met in a way that's reasonable? So I think, that's going to be a very difficult problem. The potential as well of many people for paying for these additional benefits if they don't receive them with reduced take-home pay will also be a problem, since many of the employers who do not currently offer health insurance will probably pay for a major portion of the cost of being ordered to provide the insurance by Congress by simply reducing people's paychecks. That's not going to go over too well either. So, you think about the politics of health care reform, I think it's fairly straightforward. Most Americans will like the idea of regulating the heck out of the health insurance system, because health insurance is not a very well-loved entity in most places. But I don't mistake that regulatory emphasis with actual reform. Actual reform means provides insurance to the 37 million people that don't have it, and hopefully rearranging how health care is provided to people who already do have insurance to make better use of the limited dollars. what healthcare reform really is taking between $80 and $100 billion from small employers and their employees and the medical industrial complex and giving it to people who don't vote, half of the uninsured are under the age of 24, or who are politically disenfranchised. A quarter of the uninsured are members of minority groups. 30% of our nation's blacks have no insurance. 40% of our nation's Hispanic population or Latino population have no insurance. These are groups that were not cultivated really by any of the presidential candidates during the recent campaign. So, you know, you really have to give the president credit for being willing to take this on at all, because the politics of the distributional politics of healthcare reform are really quite unforgiving. Now, what can we say that's positive about the proposed plan? Well, I think that the president's willingness to take this on at all distinguishes him from the last 5 presidents, and we really ought to give him credit for it, particularly understanding how costly it is. It takes a lot of guts to even propose to do this. I think the idea of creating a public sponsor for the uninsured and small business is a superb one, and Clinton's very grand proposal will probably be scaled back by Congress to something more realistic and doable. I also think the idea of folding in workers' compensation coverage and coverage of auto insurance, medical costs, which are a tremendous problem, is a very, very large plus, one that is a very large plus for business as well as for the general public, because a lot of those services will be moved into a managed care environment where there will be some greater degree of constraint on the rise in costs. And I also believe that his avoiding the temptation to impose price controls on hospitals, doctors, and drug companies, which would have been tremendously popular politically, but which would have produced very little tangible, measurable advantage, measurable decrease in healthcare, actual healthcare cost. His willingness to avoid that temptation, I think, also deserves credit. So I believe he deserves credit for taking this issue seriously and being prepared to spend political capital he doesn't necessarily have right now to get this done. However, I also believe that the president has gotten terrible policy advice. The idea of launching a process to reform the healthcare system in secret. I mean, how do you have a secret in Washington? You know, the Washington Post had the list of the people on the task force within 2 weeks, and for ideological reasons, excluding from participating in it anybody that had any actual hands-on experience managing healthcare institutions, delivering healthcare services, or managing managed care enterprises. It seemed like, whether it was for an ideological or tactical reason, the president's advisors deliberately impoverished themselves of the knowledge or information that would have helped them perhaps do a better job. And of course, the message to the 10 million people who work in healthcare was also sort of devastating, which is basically reform isn't something that you'll be asked to help with. It's something that will be done to you. We'll be back to you in 6 or 7 months. That's hardly the way to stimulate cross-community collaboration that is really going to be the key to getting this to happen. You know, you go back east, and I mean, I live in Chicago, so I can't really carp all that much, but that's, I grew up out here. Boise was east, so I can, you know, Chicago isn't really the east either. But I think the biggest problem with all of this is the idea that you could, you know, cook up some plan in secret and then pop it on the American public with a massive marketing campaign and expect us all to go, great, go do it. What did you learn out here in the almost 8-year-long struggle to reform this state's healthcare system? Well, here's what I think as a emigre Oregonian I think you learned. That the general public is a hell of a lot smarter about healthcare than university and foundation health policy establishment. That when you create a broad-based, consultative process in which people can participate, regardless of what they've got after their name or whether they're on the giving or receiving end of healthcare, they end up making a substantive, positive contribution. That they care passionately about their healthcare system, and that given the opportunity of broad public discussion, will agree to changes in its focus and priorities that are revolutionary to the closed-room crowd back in Washington. Going back east to the Boswash corridor, which is the healthcare reality for most of these policy advisors, is like visiting a time warp. These institutions, that they're 100 years old, they put, you know, sort of stuffed industrialists and their wives on the board. Their management structures and philosophies haven't changed in a generation. They're at war with their doctors. How on earth can people use that as a model from which to proceed towards healthcare reform when it's clear that's not the way it's going to work? when you tell people back east that most of the goals of healthcare reform and then some are in the process of being achieved in places like Oregon without a massive new regulatory intervention. The delivery system rationalization, 63% of the elderly in managed care plans voluntarily and apparently happy with it, universal coverage on the way. They dismiss it with airy pop sociology. Well, there must be something in the air out there. Well, they're right. There is something in the air out here, and it isn't clouds of political rhetoric, blaming or finger pointing. What's in the air is real change from the community level up, not the top down, in how healthcare is delivered, how physicians, hospitals, health plans, and families work together. I can quarrel at the margins with some aspects of your recently enacted health plan, such as the mandate to employers as the financing source, and I'm confident that the regulatory crowd in Washington may not be so free with their waivers for you if they actually get their proposed system passed. But indeed, the intractability of the problem as seen through the fogged Coke bottle lenses in Washington suggests that at least half the states in our country will follow your lead and pass comprehensive health reforms before we have any meaningful legislation from Congress. The problem is that the states with real problems, like California, with the burden of illegal immigration collapsing inner city health systems, states like California and New York are losing their capacity to finance healthcare reform as their economies deteriorate and may never be able to do so. The lack of a national health policy could doom many of these states to a downward economic spiral of job loss, rising employer cost burdens, and more job loss. So the failure to act at the federal level really does have significant consequences for tens of millions of people, including tens of millions of people who are in great need. Even as state and federal policymakers grapple with health reform, many of the structural changes in health services anticipated by these reform proposals, the creation of networks, the banding together of physicians into larger accountable enterprises, the elimination of excess hospital capacity, and the support of primary care physician services are happening on their own. Without the tender mercies of government oversight, health providers understand that they're going to need to be accountable for the cost and quality of care, and in many places in the country, including here, I see a genuine commitment to doing this. The good news is that the momentum in this direction is so strong that it is probably not reversible, even by major acts of legislation. What's so sad about the battles our president faces this fall is that in both cases, NAFTA and healthcare reform, there are powerful societal benefits to be achieved by solving these problems, but at the price of risk, uncertainty, and transient economic dislocation. Our pain threshold as a society is so low that our Congress and presidency cannot accomplish anything meaningful that even remotely causes anyone pain or uncertainty. The theater of the absurd, of, the syntax, but we're going to exempt beer because Bubba drinks it. Have you seen Bubba lately? I mean, why shouldn't Bubba pay actually a little bit more to cover his health care risk down the road? I mean, you can really fake yourself out by trying to avoid offending people in the course of trying to get this done. We need an effective presidency to convince us that longer-term gains are worth the price of transient dislocation. But to have an effective presidency, we must also have a citizenry that's no longer willing to be lied to, that does not beg to be, that is willing to be led. The key realities of running our government or changing our society are not always pleasant realities, and if we continue to be prey to politicians who tell us, sure, you can balance the budget and cut taxes, raise defense spending, or you can balance the budget by the middle class not having to give up anything, I mean, give me a break. At some point, it's no longer going to be possible to sell us that kind of stuff. And at that point, perhaps it will be a little easier for our politicians to avoid the whining and special pleading and to do things that really are in the broad societal interest. My talk this afternoon may seem a little negative. The good news is that I think health care reform is going to happen anyway, regardless of this president's proposals or this Congress's response. The momentum is too great at the community level to stop it. And a lot of people are going to be flying out here from back east to figure out how you did it. Good luck to you, and thank you very much.
I want to invite Gail Johnson and then Norma Curbs, and then line up behind the microphone.
Actually, I have two questions. He asked me before what the question might be, and I gave him a brief answer. Then I added another. As a former healthcare professional, I'm going to go down to the level that I had occasion to deal with. There's an assumption that healthcare is available for those that receive welfare, Medicare, Medicaid. In reality, their healthcare is limited, sometimes by doctors that either restrict or do not accept these patients. One of the glaring areas is obstetrics. How will this change with this new plan or policy? That's one question. The second question is in my current profession, which deals in labor relations, and my concern for employers bearing a larger cost. How will collective bargaining impact these benefits in this plan?
Well, on the first one, I think one of the nice things about the President's proposals, the Medicaid program will go away. The money that states are currently devoting to pay for services, to medical services to the indigent, will be given in a large lump to the Health Alliance. And Medicaid recipients there won't be Medicaid recipients anymore. They will simply have a choice of health plan options similar to that by the employed workforce. Now in Chicago, that's going to be an interesting challenge because there's whole, tens of square miles in our city where there's very little healthcare infrastructure available for them to use. But in smaller communities, I think you're going to see a marked improvement in the choices available, particularly to the Medicaid patient. With Medicare, I mean, I don't know. My impression is that in a lot of places, Medicare patients are still able to see their physician and are not subject to the same kinds of restrictions. And as physician incomes level or decline, that people are beginning to re-examine how important that elderly person is to their overall practice. On the collective bargaining front, remember only 12% of our private workforce of our workforce is unionized. I think that clearly the major unions that are our core constituencies in the Democratic Party have been persuaded that the rights that they have won at the collective bargaining table will not be abrogated or restricted or reduced as a result of this legislation. The First Lady, very early in the process, put her foot down about so-called givebacks, the idea that people would be losing the tax deductibility of their health benefits. So I think that you're going to see a lot of protections in the collective bargaining status of health benefits built into the President's proposal simply to shore up the political base for this. How long those protections extend out into the future, though, beyond 1997 or 1998 is going to be an interesting question.
Norma Curb, City Club member. In light of this rocky road, political road that you've described, that the administration is going to have to go down in order to accomplish national reform, do you envision that the administration will support the states like Oregon, Washington, Florida, where state reform has actually begun and is pretty far along?
Well, there is a powerful interest in getting the reform process underway, and you did receive your waiver back a couple months ago. The Bush administration was unable or unwilling to give you. But I really wonder whether you're going to have a sufficient amount of regulatory teeth in the Oregon Health Plan to meet muster with this new National Health Board standards, and whether whenever what legislation is passed, people won't come back and look at the structure you put in place and say, you're not beating up on the insurance firms in your state enough to satisfy our new federal standards. So I think, sure, for the 2 years worth of gridlock and rhetoric that we're going to be getting out of this, absolutely, you're going to have an opportunity to go do this. But I think at some point, if the President's proposal actually clears Congress, people are going to go back and apply those congressional standards retroactively to the structure you have in place. And if it isn't constraining enough, or if health costs continue rising more rapidly than the National Health Board says they ought to, well, then you're going to have some pretty fancy negotiating to do.
Joe Lidrich, the City Club, and I'll try and make this question short. I don't have any idea what short is. There's no one's ever said that. But I look at things very different than you did. I think Clinton's presidency, his administration, has already made a dramatic effect. And I would point out to you that Medicare is $5 billion, the Medicare bill is $5 billion less than was anticipated. I think the reasons for this is because a large number of FBI agents who did counterintelligence now essentially do accounting on healthcare costs. There are indictments been leveled. To give you another example, which I consider an extremely potent sign of Clinton's clout, my investments in the healthcare industry took a 25% chop in one day. You've let loose a powerful force, and I'd like to take your analogy of the Mississippi River. It's going to flow from the north to the Gulf of Mexico. There may be a little town like that has a dam at Appalachia.
Could you kind of come to the conclusion of your question, please?
Yes. That's why I would like to know what the time of a short question is. Yeah. Okay. The forces are the important things. The details that you are worried about aren't. Do you agree with that?
That's a very Zen question. It kind of arced around and ate its own tail. I'm not sure I agree with you. I mean, I think clearly the president's rhetorical attack on the drug companies, I mean, it took $100 billion off the market value of the drug and biotech companies and slammed the door on new product offerings for the biotech firms. I mean, they just put them in deep freeze. So, sure, the markets are very anxious about what the government might do. Has Clinton been tough on Medicare? Are you kidding? You know, this new budget package pared 5.6% off $1 trillion in spending. 5.6%. I certainly don't consider that to be draconian. Are my provider clients running for the bomb shelter as a result of all these new cost containment initiatives? Not really. I think they're taking longer-term measures to make sure their cost position is sustainable under managed care, but I don't see a great deal of fear of this administration. There's a lot of uncertainty, but I don't see a lot of fear.
Ted Falk, member. Jeff, one of the things that you said that we have done right in Oregon is the use of a public meetings process and the consultation with people, the sort of process that Oregon Health Decisions did for the Medicaid program. I'm wondering how you think a process like that could be accomplished nationally and what could be done to create the political support for this plan that you say is now lacking.
You've gotten into an area that is not my area of expertise at all. I think part of the reason why you were able to accomplish Oregon Health Decisions is because you had a limited number of communities and people could see each other face to face across rooms. How you do what you did in Oregon and Chicago, I have trouble imagining. There's a lot of places where there just aren't communities anymore. Where even the schools are sort of battlegrounds or war zones. There's nothing that really unites them. But I think the idea of town meetings that aren't staged photo opportunities for members of the administration, but opportunities for people really to be able to get up and express their own views about how healthcare ought to change. I mean, your process resembled a constitutional convention almost, didn't it? I mean, it had a lot of the same features of a constitutional convention. I'm not sure it's completely infeasible in other parts of the country. But the point that I'm trying to impress on people is it took years to do it. Years. It's a question of cooking up a proposal and then trying to shove it in people's ear in 90 days or something like that. It doesn't work that way. I mean, I think it's going to take months just for people to understand what the proposal is, let alone how it's going to actually change the way in which they get health care. So I think that the most important part of this may well be time, not the process itself.
Ray Polani, a City Club member. Dr. Goldsmith, I think it seems to me that the question is pay as you go when you're well or pay when you're sick. What I'm trying to say is you either pay a little all the time for when you're sick, or you pay when you're sick and you pay substantially. What I'm trying to say is somehow you've got to take out the profit from being sick. If somebody benefits when you're sick, there is a tendency to over-cure and do more when you're sick, but not when you're well. The concept of prepay, in other words, prepaid medical care, is that what we're going to get, you think? Or are we moving in that direction, or what?
Well, it's already here. I mean, what percentage of the people in this room are a part of a health maintenance organization? See, I mean, it's all around you. So the answer is it's already here. And under your insurance arrangements, when you get sick, it's a cost to your health plan, not a profit. So, there's problems with that too. But I really believe that the flaw in this whole business is the idea of a casualty model of health insurance. Why are we using a casualty model of insurance for a risk that people mediate themselves by the way in which they live their lives? That's the part I have a problem with. If we can't solve the problem alone just by holding providers of care at risk for the cost of care. If the kid who runs into a motorcycle, on his motorcycle and runs into a bridge abutment has the same entitlement to coverage as the kid who wears the helmet, then there's something wrong with our insurance system. And I think we ought to stop using the term insurance and begin using a term that actually implicates people in the health and cost consequences of their own behavior.
Hello, I'm John Moreland, City Club. You had a couple of different kinds of criticisms of the current situation. One was on the process arrived at a proposed plan. But then you seemed to be negative on two different alternatives. One was the current plan, which involves creating a bureaucratic funnel for the funds supplying health care. But you didn't seem to be very positive on, say, the Canadian sort of system. And I'm wondering if you could say, what would be, in your mind, the appropriate, at least general structure of a nationalized health plan?
Well, I really like the Heritage Foundation model myself, the idea that it isn't the corporation that is mandated to provide coverage, but the individual that is mandated to buy it, and that you fund the purchase of the insurance through refundable tax credits for those individuals that do not have the money to do it themselves. What was missing from the Heritage Foundation proposal was the clearinghouse, that is the ability to aggregate the purchasing power of all those individuals. The Heritage Foundation would have just turned people loose with their vouchers, and that scares me a little bit, not because I don't think people can make good choices, because I think there would have been a lot of bad choices. I really think that the moving from the Medicare program out approach and implementing a voucher-style approach to getting the uninsured enfranchised in healthcare insurance is the best way to go. The Canadian system, I mean, this is no longer an issue of fact; it's an issue of religion, and it's really very difficult to argue with people who think that if Canada's solved it, why can't we? One of the slides I wasn't able to show you this afternoon is, if you strip away the gross national product comparisons, per capita health spending in Canada has grown at almost an identical rate to our own over the last 20 years. And when you confront the Canadian health economists with this, and they say, well, we have a very powerful medical care establishment in Canada. It has a lot of political influence. And you're saying, well, gee, is that we go through all of this brain damage, and then we're back to the political system to contain the cost of health care. How much confidence do we have in our political system to do that? That, to me, is the acid test for whether a Canadian system works, not whether a particular sluice work of funds is more conceptually attractive.
I'm Bob Shoemaker, member of the club. I'm also the chair of the Oregon Senate Committee on Health Care, so I've been very involved in these issues. We have an employer mandate in Oregon, which is now scheduled to go into effect in 1997. It became apparent during the last session that there's a great deal of opposition to that, not only among the small employers who may not now be providing health care, but even among the large employers. So I'd say that the employer mandate is in some jeopardy in this example of a community health plan. We're going to be looking at alternatives, and the one that looks the most likely you might call an individual mandate. It's like the Heritage Foundation's proposal, except that it's not voluntary. You do it through an income tax and make everybody essentially pay a health care premium through their income tax, then give them a credit if they get their health care through their employer. I'd be interested in your comments on that in terms of whether you think that makes sense, and also whether the administration gave some serious consideration to something like that, and if they did, why that isn't within their proposal.
Well, I have no idea whether the administration had considered and rejected that alternative. I think that they were committed to mandated benefits in the campaign, and that was just one of the cornerstones from which policy was developed. I like the idea that you suggested. You know, it's interesting. I end up agreeing with Donna Shalala. I think the right way to have financed all of this was with a value-added tax, a tax on consumption, not income, a tax that offset taxes that, like the capital gains tax, that discourage investment. I think that really would have been the right approach. I mean, if you don't have that option, and you're considering a sales tax here in the state for other reasons, I think the idea of using the income tax system and an individual mandate as a vehicle for doing it is a very good idea indeed. The other thing where I think Clinton is going to drop the ball is on the idea of not requiring individuals to purchase insurance. There are going to be two gaping holes. You're not going to have universal health insurance if you leave to people the choice of whether they're going to use it. Healthy young people will say, no, I want to use it for my motorcycle payments, thank you very much. Or no, I want to use it for my groceries because my kids aren't eating, thank you very much. They're only taking home $80 a week. So the 2 months after the completion of the phase-in of universal health insurance, you're going to have 15 million uninsured people in this country, plus the undocumented. Okay, so, I mean, what have you haven't really closed the door. I think the individual mandate is the right way to go. I think I really believe what a lot of the people that have lobbied against the mandate here in the state believe, that mandated benefits destroy jobs, and that it's, you know, the door is open to just heaping onto the employer's back the cost of benefits that we're not willing to raise taxes for in the public realm to provide to people as a public good.
I'm Louis Simpson, and my question to you, Dr. Goldsmith, incidentally, I think it was an excellent presentation, but my question is, what about the varying prices? You know, you think of the delicate operations that are conducted, or you think of elder care and long-term care, all the expenses involved with those. How will this plan cover them?
Well, that's one of the areas where I think we really are going to have to wait for the details. The President has been backing away from the extraordinarily comprehensive benefits package that the First Lady committed to during the spring and summer, simply because of no new tax money. You read this morning they're going to be pulling back on mental health benefits. They're still fabulous compared to what most people can buy, but or what most people are getting now, but they're certainly not what the mental health lobby expected. There is a lot of rhetoric about expanded access to home care services and services that will be added to the Medicare program for the elderly, but I frankly don't know. And I think they're probably still deciding. I mean, this is sort of like, you know, very much related to how much money you have to pay for it. And I think they're finally getting around this week to making those decisions.
I have a question, actually it's a trio of questions from the floor that we'll use perhaps as our last question. And the question is, with the shrinkage of fee-for-service, will there be fewer doctors? Can we expect a grand BMW sale? And will the small business owner be able to afford one?
Oh. Wicked wit out there. With a shrinkage in the fee-for-service sector, will there be fewer doctors? No, there won't. There will be more doctors. They will make less. The specialists will make a lot less. Can we expect a grand BMW sale? That took place several years ago when they traded them in for Lexuses and Infinities. I didn't mean that to sound as catty as it did, but people, they don't have BMWs anymore. Will a small business owner be able to afford one? I don't know. I mean, I am anxious about small business. I used to be a small business, but I still am a small business person. I'm an employer of one very small person. I guess that makes me a small business. I think that there's a lot of other things in the works for small business too besides the mandate. There's the prospect of a minimum wage increase to 5 or 5.25 an hour ultimately. There's the cost of parental leave. I mean, all of these things have, each one of them, something good to recommend them. But when you heap them all on at the same time and then turn around and say, well, yeah, create 8 million new jobs, I mean, it's very much of an either-or thing. And, I know the administration's planners are enamored of Germany, where benefits are 87% of wages. And they sort of say, well, gee, we're only 37%. You could bump that up a little bit and we'd still be competitive. But, well, look at Germany. Germany is flat on its can. And the main reason is because their labor costs are completely out of control and their productivity has gone through the floor. So, I mean, Germany's going to have to begin doing something about the cost of labor, or they're not going to be an international, they're not going to, you're not going to have the BMWs over here and the numbers that people would like. So I'm concerned about the small business impact.
Well, as we thought, I think Jeff's talk has been very illuminating, and I'm sure you would join me in thanking him for his talk today. We're adjourned.